Good afternoon, everyone, or perhaps good morning still for some, but welcome. Thank you for taking the time to join us for today's forum that we're really excited about. My name is Delia Wesley, and I'm the Senior Director of Health Equity at Mathematica. I'm so honored to kick off today's forum, in which we will take a deep dive into our topic of how payers can help address social determinants of health. At Mathematica, health equity is central to our 2035 vision of shaping an equitable and just world and using evidence to drive decisions. The imperative is that addressing social determinants of health is a primary approach to advancing health equity, and we cannot expect to effectively move the needle towards achieving equity without doing so. Ensuring that all individuals have the opportunity to not only achieve optimal health, but to maintain that health status requires a holistic approach to providing care, and ensuring that any factors that impede this goal are effectively identified, addressed, and tracked. Healthcare payers from public and private sectors have a unique opportunity here to establish and reinforce incentives for whole person, community-centered care that reflects those principles. There's an opportunity to ensure that there is no disadvantage to an individual because of their social position or any circumstances that are otherwise socially determined. And so really centering payment models and benefits around the needs of patients and families, including factors such as housing, healthy food access, health-harming legal needs, amongst others, and not just around medical care, can help payers and really their partners promote health equity and better meet the needs of their members and beneficiaries. At a time where many are grappling with how to address these issues and recognizing that well-intentioned efforts to improve quality of care can oftentimes exacerbate these very healthcare disparities that we aim to address, our goal today is to be part of the solution. And so by bringing together several experts, we hope to provide key insights today to inform the many who we know are eager to move forward with addressing the health-related and really the health-harming social needs to advance equity. We'll hear today about feasible solutions currently in place across the country, key innovations and lessons learned, strategies that could potentially work for a variety of different payer and provider types, and that could work in different contexts. It is my pleasure to introduce our panel for today. You'll have access to full bios for every one of our speakers. And the first person I'd like to introduce today is our moderator. Cynthia Hernandez-Cancillo is a vice president at the National Partnership for Women and Families, where she leads the health justice team. She's a thought leader on national health and healthcare equity policy and advocacy with 25 years of experience advancing equal opportunity for women and families of color, and almost 20 years of experience advocating for increased healthcare access and improved quality of care for underserved communities. Chris Demars is the interim director of the Delivery Systems Innovation Office and the director of the Transformation Center at the Oregon Health Authority, where she oversees policy and programs that support delivery system innovation and quality improvement for Oregon's health system reform efforts. She also plays a lead role in the agency's value-based payment and social determinants of health work. Dr. Len Nichols is a non-resident fellow of the Health Policy Center of the Urban Institute and professor emeritus of health policy at the George Mason University. He's a health economist and the principal investigator of the Collaborative Approach to Public Good Investments project. Len has been intimately involved in health reform debates, policy development, and communication with the media and policymakers for more than 25 years. Dr. Kara Odom-Walker is Executive Vice President and Chief Population Health Officer for Demars Children's Health System. She leads Delaware Valley Primary Care, the Value-Based Services Organization, and the Demars National Office of Policy and Prevention. Dr. Walker joined Demars after public service to the state of Delaware as the Secretary of the Delaware Department of Health and Human and Social Services, And then finally, Dr. Tony Abrams-Weintraub, who is a physician researcher here at Mathematica with more than 2 decades of experience in public and community health, health promotion, and health policy research. She specializes in social determinants of health, linkages between clinical care and social services, and community-based and cross-sector health initiatives with a focus on under-resourced communities. I'd like to extend a warm welcome and thank you to all of our speakers today and to all of you, our attendees. And with that, I'll hand it over to Cincy to get us started with the discussion.
Thank you so much, Delia. Good afternoon, buenas tardes. I am really excited about this conversation. Thank you, Mathematica, for hosting this critical conversation on this critical issue and for the opportunity to be part of it. I do want to offer some initial thoughts to kick off the discussion. First, what are we trying to solve for when we say that healthcare should take a more active role in addressing social determinants of health and advancing equity. I think all of our answers may vary some, but I believe that the core of where we are is that we want to improve the nation's health, especially in communities, geographic or demographic, that have been structurally disadvantaged so that we can all thrive together. From a health equity perspective, this purpose is rooted in a fundamental belief that every single human being in this country deserves to be as healthy as possible. It is simply not possible to have a healthy nation, a strong, sustainable economy, and resilient, thriving communities unless we are very intentional about improving overall health and eliminating health and healthcare inequities. So what do social determinants have to do with it? Addressing social determinants is the only pathway to whole person care. It must take into consideration the individual social determinants, both that are adverse and those that are positive, in developing and implementing care plans. Because let's please remember, we shorthand a lot thinking we need to fix social determinants, but for a lot of people, their social determinants are working quite well for them. And we all have a mix of positive and adverse determinants. There is also a very fine point for us to remember that often gets lost, is that social determinants, social risk, and social needs are not the same thing, right? And so let's be very explicit about what we're talking about when we are thinking about these strategies. And at the end of the day, whole person care and care that is cost effective over the long term is not just restoring health. It is also maximizing real concrete opportunities to achieve and maintain good health. And that means getting rid of a lot of longstanding barriers that people and communities face in being able to achieve optimum health. It is necessary to achieving health equity and socioeconomic equity more broadly. You cannot, if we're not looking at social determinants of health, we cannot solve these very intractable issues that we're dealing with. And but at the same time, we need to be explicit in solving for racial, ethnic, and other inequities. Social determinants by themselves are determined by interpersonal and systemic racism, for example, in addition to other kinds of social inequality. So working on social determinants of health without an explicit racial equity orientation will not advance health equity. And it is more important than ever, given all the demographic changes that are happening in this nation. Right now, the majority of children in this country, the people that we expect to in the next 10 to 15 years grow up and be, contributing members of society and pay their taxes and pay into the Medicare trust fund, et cetera, we have about 10 or 15 years to make sure that they are healthy and thrive, and the majority of them are kids of color. So what can healthcare do about it? The challenge is that healthcare historically has been focused on treating illness. And so how do we shift what is almost 1/6 of our economy into an industry that maximizes opportunities to achieve and maintain good health, and do it by leaning into addressing the root causes of poor health? It won't be easy. It will require collaboration among many stakeholders, including the affected communities and individuals themselves. And healthcare payers must play a key role. It really cannot happen without you. And so what we need to see is for payers to pay for those things that we know actually work to improve health. It's not just incentives. It's also what kind of upfront and ongoing investments are necessary to build a healthcare infrastructure that we need to remedy what is generations of disinvestment and exclusion in communities and in healthcare. How do we build on community assets and community-based organizations who are the ones that have expertise and trust to be able to address some of these issues? How do we dismantle our own individual biases and organizational biases that can affect how we take on this work? And how do we create accountability? And to do that, how do we make sure that we have data systems that can track, that can identify where the inequities are and can track how we're doing in terms of progress? It's not easy for the healthcare industry to figure out how to pay for addressing social determinants of health because it hasn't been your domain. So how should a payer start to think about getting on that path? And how can we make sure that any approach is sustainable? That's the purpose of today's discussion. And we have with us leading experts whose organizations have started down that path, and we can learn from their experience. And I feel very honored to be in the same kind of virtual room with these experts. So, and there's a question about how to provide questions for the attendees. So please, if somebody could clarify that, and we'll get going. So let's get started. My first question is for Chris. Effectively addressing social determinants of health requires Medicaid to play a key role. How are states such as Oregon using payment incentives to address social determinants of health? And what have you been learning in this process?
Thank you, Cincy, and thank you for the opportunity to tell Oregon's journey in 4 minutes. So I'm going to try to capture a lot of work in just in a few minutes. So first, setting the foundation for Oregon's Medicaid program, we have what are called coordinated care organizations, which are kind of like accountable care organizations that serve about 90% of Oregon's Medicaid members. CCOs receive a fixed monthly budget that grows at a rate of no more than 3.4% a year to coordinate care for their members. And they also receive financial incentives for improving outcomes and quality through an incentive metric program. And that's key for some of the programs I'll be talking about. So when the CCOs were created in 2011, their original vision was to improve Medicaid member health by comprehensively supporting their needs via both medical care and to go more upstream, addressing social determinants of health. So we built in a number of levers to address health-related social needs through CCOs. And so while notable progress was made during the first number of years that CCOs were in place, Oregon's governor requested enhanced contractual requirements to address social determinants of health and promote health equity in what we call in the second CCO contract, which we call CCO 2.0, which was put in place in 2020. So what I'm going to be doing now is talking about some of the programs that have been in place and kind of enhanced since over the last decade. So first, I'll be talking about two spending programs, or the ways that CCOs can address their members' social determinants of health. And the first is called health-related services. So I mentioned that CCOs have a global budget that provides CCOs with flexibility to address their members' needs outside of the traditional medical services. And so they can take advantage of this program called health-related services, which are non-covered services under Oregon's Medicaid state plan intended to improve care delivery and overall member and community health. And so they can provide services that address individuals or community-based kind of supports to address social determinants of health. And examples are prescriptions for vegetables, farmers markets, bike share programs, accessible playground equipment, etc. So health-related services, great program. The one problem with it is that from the CCO's perspective, and it's very understandable, is that their costs hopefully will decrease. There's, in which case their future budgets will be decreased as well. And so we've developed a new program put in place within the last year called the Performance-Based Reward Program, which is that CCOs that use health-related services to improve health and reduce medical costs receive a higher margin in their capitation rates. And I won't get into a lot of detail about that because I don't have time today, but it's a really exciting new initiative. The other spending program I want to briefly mention is called the SHARE initiative, or Spending Health for All Through Reinvestment. And this was put in place much more recently. It started in 2021, this year. And it was a result of state legislation, which says that CCOs must spend a portion of their prior year's net income or reserves on addressing their members' social determinants of health and promoting health equity. So health-related services is spending through the year. The SHARE initiative is spending that is a portion of what they have kind of left over. And so these programs are complementary in that way. The other two strategies that are related to health, social determinants of health spending that I want to briefly mention is CCOs are all required to have a community advisory council, which is comprised of a majority of Medicaid members and other members of the community. And the CACs for every CCO has to have a role in spending for health-related services, community benefit initiative programs, and also share initiative spending. And they also need to oversee the development of a community health improvement plan for the CCO. Spending for both of those programs I explained must be aligned with the CHIP, the Community Health Improvement Plan priorities. Lastly, there's a new initiative that we have kind of on the horizon, which is a new proposed screening metric for screening for social determinants of health or health-related social needs that would go into the CCO's incentive metric program that will, if it goes through as adopted, would be in place in 2023. So with that, I will stop. And I have other lessons that we've learned, but I'll touch on those throughout the rest of the hour. Thank you.
I'd like to ask if any of the other panelists want to add anything on the question of, how Medicaid is doing, taking advantage of addressing social determinants of health.
So, Cincy, I might just add that not everybody has to go as fast and as far as Oregon, but God bless them. And I wish we could clone Chris and just spread her around the country. But there are simpler ways to accomplish similar objectives. And Ohio is an example I will call to your attention. What they did in their last MCO procurement, they just put in the RFP, tell us what you're doing now in the social determinant space, and tell us what you intend to do in the future. And if you do the right stuff, and we can talk about that, then you can count some of that toward an MLR, and it won't penalize you in the rate setting in a future year. So it really takes into account the key elements Chris just laid out. Recognize that funds have to be allowed to be spent on non-health services, and you can't penalize the health plans for doing it. You've got to reward them for doing it, and there are lots of ways to pull that off. But Chris has what I would call 3.0, Ohio's at 2.0, and something in between is good for the country.
Yeah, I'd like to jump in too. I agree. Chris, amazing work in Oregon. In Delaware, we had opportunities to think about incentivizing social determinants of health work through our Medicaid program. But I would say there are ways to do that that are small and large. At the state level, we knew who was a Medicaid eligible recipient. Some of those same individuals were not accessing other social services. We need to have increased investments through connecting to the social services block grant, other substance use mental health needs that have additional flexibility to pay for things like getting a car repaired, making sure there's job training opportunities. It required a little bit more legwork, and it wasn't quite as organized as the Oregon approach, but I would say that those are meaningful opportunities where Medicaid can play a significant role, and we saw the MCOs interested and willing. I think the other way is kind of the North Carolina model where you create infrastructure to do that work. So creating a platform where those referrals to the community-based organizations is streamlined could be incredibly valuable as well.
Thank you so much. So Len, now I have a question for you. Switching from Medicaid to Medicare, Medicare managed care has begun to address social determinants of health through payment. How can fee-for-service Medicare use payment to help address social determinants of health most effectively? And how can it leverage its portfolio of existing models in support of this goal?
Great question, and one of the things that a lot of us have been worried about for some time, because we've got Medicaid MCOs reasonably far down the road. Medicare Advantage plans are now being allowed to do more creative things, and Medicare fee-for-service is sitting over here with its hands tied behind its back because we haven't allowed the Medicare program to pay for social services that don't have a CPT code. God forbid. So you've got to have a CPT code to get paid in fee-for-service Medicare. So the first thing is, let's all take a deep breath and think about empowering clinicians to do what they want to do, which is to solve people's problems. And some of those solutions we now recognize, and even clinicians recognize, extend beyond what medical care can do. And so the first thing is, let's look at what the health plans are doing in Medicaid and Medicare and allow fee-for-service Medicare to pay for that. Give the ACOs billing codes. Give them the ability to spend money on this. You could do PMPM to make it simple and talk about specific services you want to cover. I love the way Oregon ties ultimate performance metrics to these extra payments, because that allows you to do something other than just worry about saving money. Because, you know, it turns out we don't require a new drug to offset hospital and physician spending in complete ability to offset the cost of the drug. We just want the drug to improve health. We want a new medical procedure to improve health. Well, we should think the same way about social needs that are also enhancing health. That should be the criteria. And with that criteria in all programs, we can go a long way.
Sorry, I had to remember to unmute myself. Of course, there would not be a webinar without at least somebody having that issue. Len, what I was saying is that that you make a really good point about the fact that we've gone down this road of needing to show value in healthcare in dollars and cents as opposed to in improved health. And so that is a real challenge because it's the entire payment system is structured around that. Does anybody else have any additional comments around the issue of how can Medicare fee-for-service address social determinants of health more effectively?
Yeah, I can jump in here. Thanks, Len, for those comments. I'm totally on the same page. I think one way that Medicare can do this is by attaching reimbursements to the existing set of Z codes that represent some social determinants of health and risks, and regardless of, and to allow that reimbursement regardless of who on the team actually conducts the social needs screening. I think doing so would also advance the data collection that will document these types of needs and the volume of needs and the risk level of a patient population. And that can inform further policies and investments to expand and align the community services necessary to address those needs.
And I don't have an answer to the question about Medicare, but I do want to just echo what Len said in terms of setting a goal and allowing for kind of flexibility with regard to how that goal can be met. And that's obviously what Oregon has done with its incentive metrics. And I just wanted to note that I didn't mention value-based payment, but I heard Len mention that. And I think that is just such a key strategy to help support the work we're talking about, providing kind of a capitated payment with quality incentives, metrics that are tied to that, or the PMPM that Len mentioned, that provides the flexibility at the provider level to really meet members' needs and not have to kind of work along the fee-for-service kind of volume approach to care delivery.
Anybody else have?
Yeah, I just also want to say I really like the analogy. Sorry, I really like the analogy, Len, that you used with, new medications and how we don't set that same standard for them having to pay for themselves. And, there are other ways to measure success in addressing social needs. And thanks for bringing that up.
Yeah, that is certainly one of the fundamental challenges around when we think about how do we transform the payment system, because that has been the way in thinking about alternative payments and value-based models, we're kind of strapped into this, things have to pay for themselves. And we need to figure out how we deal with that barrier. So my next question is for Kara. I'm sorry, I'm not sure if it's Kara or Kara. Kara. Your experience in particular spans a wide range of environments and groups. To what extent are these solutions transferable across different populations, providers, and payers? how and where do we need to customize?
Thanks for that question. I think it is the biggest challenge. I'm a family physician by training, but now in a children's health system that's trying to figure this out. And Demars has the opportunity to work across payers, work with communities, and really think about how we invest in the social determinants of health. I think my state experience in the Medicaid space really aligned with this well, but now in this health system world, we're trying to think about family context all the time and then work with our commercial payers and others. I think the solutions are about measuring and contrasting the here and now and the investment strategy. How do you think about both at the same time? And I think there are three key opportunities. One is screening and referral. The second is adding equity measures. And the third is incentivizing provider delivery system reform efforts. So I'll mention a tidbit about each of those. We could talk more in the Q&A. But I think around screening and referral, there are opportunities to leverage what we're learning in Medicaid and apply it to other payers. It's relevant to the conversation we had earlier about Z codes, incentivizing, putting more resources into community settings. It's also relevant in the context of dual generation, multi-generation families, where we know those social factors are so important and allow us to get out of our silo of it's only about Johnny in front of me, but it's really about the whole family unit and how we create better health outcomes for them. I think the second one around adding equity measures forces us to have the conversation about social factors. If we start to parse out outcomes by race, ethnicity, geography, we will find co-located needs that are geographic in nature, where we can say, we need the community health worker here. We don't need it over there. We really need to make sure we're getting flu vaccinations out every Saturday in October in this community, because that's where we're having gaps and people have other barriers that are facing them. I think that's an opportunity to layer in no matter what payer segment, right? Work with the large employers, work with others, because even at Demars, at the level that I sit, we have disparities among our own associates that we're trying to address and overcome and make things easier. I think this is a place where smaller provider groups can also be interested in that feedback, that data loop, to understand where they can do additional outreach. I think the third one is maybe leaning a little more on my policy and research hat a bit, where we think about the delivery system reform. Using those payer dollars, we can think about non-traditional sources of funding that could be pooled together. So it doesn't have to be just Medicaid, it doesn't have to be state general funds, it doesn't have to only be federal funds, but how do we pull funding cross-sector together? And there are some innovative ways. Some on this panel are more expert than I, but around creating wellness funds that allow us to invest early and upstream to really get dollars on the table that are coming from philanthropy, employer coalitions, and federal and state funds, I think can make an impact and allow us to get upstream and address some of these wrong pocket, long pocket issues that we know are significant. I think some states have done this well around collective impact funding, legislating it, trying to figure out how to put some funding into things like primary care. They call it primary care, but in actuality, it's how does healthcare address these barriers around access, around making sure we're allowing for a team-based approach. In Delaware, we had leveraged some lessons in Rhode Island around legislating a target to pay for primary care and delivery system innovation, where setting a target for 11% in the commercial payer segment could incentivize and encourage how we get there. So I think this requires a lot of advocacy and collaboration, getting out of our box a bit. But I think really thinking about the collective impact, social impact bonds, how we can push forward around these upstream factors are critically important when you're thinking outside of Medicaid or Medicare.
So I have a clarifying question for you, Carol. When you say, and I 100% agree that you need to have equity measures, what you mean is not like there's some efforts, there have been efforts to do like equity indexes or like just measures around equity kind of, as opposed to making sure that you are collecting the race ethnicity data and that you are disaggregating outcomes and results and information and stratifying them by race, ethnicity, and other categories. Is that correct?
Thank you, Susie. I think that's absolutely correct. And the ability to have it transparently published so community can see where these disparities are. So it's not just about, one group saying that we think it's asthma or we think it's lead testing, but it's really a collective that says we actually believe that this is a problem and we want to overcome. If we measure things like flu vaccination rate at a payer level and just add that in as a bonus payment to providers, I don't think that gets at the underlying issue that we want to address. What we need is that engagement, that understanding of what is really creating that asthma disparity in a particular neighborhood or community. And I absolutely agree with you. It's not just about creating this index to check the box. We're really trying to create some action and collaboration.
Excellent. Thank you. Does anybody else have something they want to add around this issue? Especially around the tailoring issue, I think.
I have some thoughts, brief thoughts. I completely agree with Kara and Cincy, your comments around data and stratifying data and getting good data, which at least for Medicaid programs can be tough. And we're really trying to work on that in Oregon, but it is tough. I'd say that kind of data at the provider level and pairing that with kind of expectations around with measured benchmarks can really be effective. And then something that hasn't been brought up in the conversation yet, but I feel like is very important to touch on, is coupling that with technical assistance and capacity building strategies. And we do our best through the Transformation Center to provide TA for our CCOs and for providers to the degree we can to help build their capacity to achieve the metrics and the, kind of those performance measures that we set for them.
Thank you so much for adding that, for pointing out the need for the capacity building and the technical assistance. And, that also needs investment, right? We need to actually be able to create and sustain the entity that will be providing that. On the issue of how might you customize strategies, I think one thing to remember is that, especially if you want to make sure you are providing culturally centered care, you have to customize, right? And so it's really important to figure out how we have systems that are flexible enough so that customization can happen. And when you're in an industry, there's this idea often that, we need to leverage volume. We need to, there is administrative simplicity if everyone's getting the same thing, right? But healthcare isn't widgets. And figuring out how we balance accountability with letting each community-based organization do what they know works and do best in partnership with a provider or a health system or an insurance company is something that will be super, super important. And it's really sometimes hard to wrap your head around, especially in areas where you have many, many different diverse communities. Does anybody have anything they want to comment on that issue in particular?
Well, I would just say, Cincy, we have learned, some more slowly than others, that if you don't listen to the people you're trying to help before you design how you intend to help them, it ain't going to work. And more people have figured that out. And that's really the key to the tailoring and all that stuff you just described. And I think what we need to do is put our humble hat on and go talk to people, come back and redesign our brilliant ideas, and then set up a data strategy to actually measure how well we did across the different kinds of communities in a given locale.
I agree 100% with you, Len. And, that's one of the reasons, for example, you can also build it into your strategy, right? Like that's one of the reasons I love community health worker kind of strategies, because community health worker is like the Swiss Army knife of like a health and healthcare ecosystem, right? They are in the community when they're done right? They're in the community, they have their pulse on what people need. And they're also extremely flexible in what they're able to do. So that's a extremely important point. So I want to move on now to Tony. You've worked with providers at both the national and local levels as they engage in community-based organizations to tackle health-related social needs. What have you observed from those interactions that payers should take into account?
Yeah, thanks. I'm glad you brought up the community engagement piece and building on what Kara said. Addressing social needs requires multi-sector partnership. Clearly, the healthcare system can't do this alone, and neither can community-based organizations. The community health center system and community-oriented primary care approach that I cut my teeth on were built on the social justice principles of the 60s and began to integrate health and social needs naturally through community collaborations as the system grew. But as a standalone model that didn't permeate the fee-for-service healthcare delivery system, until now. And some of the, as Chris mentioned, many of the CCOs in Oregon are doing just that. And as we move towards adopting these principles on a broader scale, the first thing for payers and partners to anticipate is the cultural divide between sectors. So each set of stakeholders needs to learn, understand, and equally respect the perspectives and experiences of the others. We need to acknowledge and address the power differential that's based on historical attributions and the substantial imbalance between heavily resourced healthcare systems and the chronically under-resourced community-based social service organizations. And healthcare providers and payers are critical voices at that table, yet we need to help shift and neutralize that power dynamic if the partnerships are to be effective. One way to address the cultural and equity shifts necessary to do this work is through cross-sector learning and training. Creating opportunities for each sector to help build the skills and capacity of their partner organizations. So for example, an interpersonal violence agency can train healthcare staff on trauma-informed care approaches, or nutritionists can demonstrate healthier, culturally appropriate food choices at community venues. And payers might promote and support these activities. And developing the professional and interpersonal relationships and trust necessary to generate community-based and community-building efforts takes time and requires sustained investment. And payment models should recognize this and allow for that time. The second thing I want to highlight is what we've been learning about effective catalysts of community multi-sector collaboration from recent state and federal models that promote multi-sector partnerships to align health and social care, such as CMS's Accountable Health Communities or AHC model. Some key facilitators of multi-sector partnership collaboration include, one, establishing a shared vision and goals informed by the community voice, as we were talking about tailoring and really, and as Len mentioned, prioritizing what's important to the community that we're serving. Two, having organizational decision makers and community leaders at the table. Three, sharing meaningful data in a way that enables partners to prioritize activities and measure their shared progress. And four, aligning with similar local or regional efforts to create efficiencies and avoid duplication. There are lots of groups doing this. Healthcare may be newer to the table, but we want to make sure that we're trying to, really bring those efforts together. And again, all of this requires sustainable long-term financing to support both the initiatives themselves and the infrastructure that makes it possible. So one of the things that AHC Bridge organizations do is that their alignment partners conduct a community landscape scan, and together they look at the data on health-related social needs and implement strategic plans to address the priority gaps in community resources to meet the prevalent needs. And these efforts are really starting to result in some inspiring collaborations. And payers can play an active role by joining multi-sector partnerships like these and co-creating solutions to advocate for broader change, and by investing in the infrastructure and in the community services directly. And finally, I want to mention that fostering multi-sector partnership is a key step towards preventing the so-called bridge to nowhere problem. So in many communities, social services are scarce, rural areas, for example, or unable to accommodate a deluge of new referrals. So providers may perceive attempts to identify needs and connect patients to limited community resources as a quote unquote bridge to nowhere, and may worry about the ethics of even screening for issues that they can't treat. Yet I want to emphasize that screening for health-related social needs in community settings is important, even in the absence of available resources while we build the bridge, if you will. because it enables providers to adjust clinical care plans to accommodate for identified social barriers and leads to more effective treatment. For example, by prescribing an alternate antibiotic for a patient who can't refrigerate a first choice drug because they're living in their car. And research supports that screening leads to appropriate care plan adjustments and that patients appreciate when their care team understands the context of their situation. So I'll stop there and give my colleagues a chance to weigh in.
Thank you so much for that. Absolutely, one of the things that we have been very concerned about from a health equity perspective is that bridge to nowhere. We've seen a lot of interest in screen and referral, but not accompanied with the kind of investment that needs to happen so that the referral, agencies actually can provide the services, right? And so I'm really, really happy that you raise that issue, because often the instinct is like, well, let's hire a couple of community health workers that really are from the community necessarily, rather than thinking about what are the assets already out there in the community that we can support and help build up and partner with, so that we can do what our patients, provide what our patients really need to be healthy. Does anybody else want to weigh in on this issue?
Yeah, I can. I really appreciate that too, Tony. And Oregon, in developing our social determinants of health or health-related social needs screening metric that may be incorporated for the CCOs in a few years, that was definitely, and we did this through a public process. It took about a year, maybe even more. It was a concern about screening without the ability to refer and actually meet the needs. And two, inputs led us to kind of move forward with the screening measure first. And one of those inputs is some data from Siren down in California, and I can't remember what it stands for, but I imagine many of you know what that is. They've done some research on this very issue, and my recollection, I hope I don't get this wrong, is I had asked patients, members, about screening without being kind of connected to referral and how they felt about that. And my recollection that there was positive support for that for the reasons that Tony mentioned. The other is that in Oregon, at least, our vision is at some point we'll be able to get to kind of the infrastructure and connections between healthcare and social service, et cetera, to actually meet those needs. And we have a slide that we always show when we talk about our screening proposed screening measure. It shows it's an arrow that's kind of being like, this is where we're starting. And then our hope is to get to this place in the future, but we need to start somewhere. And I think this even goes back to Len's initial reaction to after I spoke and said, not everyone can be where Oregon is. Well, remember, we've been doing this for 10 years and we started small and we've been adding over time. And so, for any of these programs, start somewhere and kind of keep building. But for the SDOH screening metric, those were kind of my thoughts, echoing what Cincy and Tony said.
So unless anybody wants to add a comment, I think we're ready to move on to our last official question, and then we will be getting to your questions. And please, 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 put in your questions in the Q&A feature of this platform. So Len, you're going to close us off. There are many efforts to address social determinants of health outside of APMs that have relied on substantial initial funding. The thing is, how do you continue, right? How can we make investments in addressing social determinants of health more self-sustaining over time?
Well, Cincy, I'm just a simple country health economist, and economists think about that question. We think if you want something to be sustainable, it's going to have to be in people's interest. And so what we have done and others are trying to do is to make it more clear to more stakeholders, health plans, hospitals, all kinds of local actors, including local government, et cetera. It's in your interest to solve these problems. Now, it might be a financial interest, It might be a mission consistent interest. There are people actually who care about people and they care about outcomes and getting healthier. And organizations are committed to that. And every healthcare organization on the planet, while they have to be cognizant of bottom line, also want their patients to be healthier. So I think it's a matter almost of like lifting the veil of the way they think about the world and think about what they can do about it. Specifically, as you know, what I and my brilliant young colleague, Lauren Taylor, have been doing over the last couple of years is teaching people how to think about, look, let's just take something concrete like giving permanent supportive housing to the homeless who have SMI, serious mental illness or substance use disorder, with the supportive services that make life better quickly. And turns out if you do that well, you will benefit those homeless individuals, but you will also benefit multiple actors downstream. And that's what we mean by thinking about this in a different way as a public good, because it benefits multiple beneficiaries. When it benefits multiple beneficiaries, then you've got to show them how they can benefit individually, and it's okay if others benefit too. And that's how you get them to think about collaborating. And that's what we've been able to do in Cleveland now and Waco and Albany, and we've got maybe 6 or 7 more that are thinking about coming online. But the fundamental idea, agree as a community what you want to address together, come to understand you can probably address it better as a group than as a one-off by yourself. And you know, Cincy, one of the keys to collaboration, especially among health plans who, you might have heard this rumor, compete rather aggressively on every other dimension known to humankind, they can actually benefit if they do stuff together precisely in a world people change plans. A lot of times you talk to health plans about investing in something that's going to have a payoff down the road. They go, oh, well, then they'll leave me in 3 years. I'll never benefit from that. Well, it turns out they leave you, they go to your competitor's plan, and vice versa. The competitors' people come to you. So as long as you're keeping the human beings insured and you've got all the insurers playing, you all benefit from that investment in perpetuity. So that's the key to life, is recognizing the mutual self-interest in working together. Our model and others, some of the ones Kara mentioned, can show people technically how to combine their resources and break down those silos and, you know, do that stuff. But to make it sustainable, Cincy, it's got to be in their interest. And so I will come back finally to policy. CMS, state Medicaid agencies all have huge roles to play in expanding the ability for healthcare to do what it wants. Now, let me be clear. There are not enough healthcare savings to pay for utopia, but there's a heck of a lot of healthcare savings that could be rechanneled in a way that both serves the self-interest of the health organizations as well as the people we actually know we need to be serving far better than we have in the past.
Thank you so much for that, Len. So how have you been able to handle, and in the way you've been trying to open people's eyes, or basically widening the aperture of that, especially around time, right? The longer term implications when we are in this competitive environment. You know, I'm reminded of our friend Charlie Olafero's in New Mexico's efforts to get permanent funding for community health workers, developed a wonderful plan with one Medicaid MCO, tried to expand that across all payers, and they wanted to tweak something a little bit different here, tweak something a little bit so they could put something different in their marketing, and then that becomes completely impossible for the provider, whether they're a community health center or or small community providers that are really essential in advancing health equity, to be able to manage all these different details from different sources, of insurance. How do you get folks to actually think? I mean, yes, you're right. We all can agree that we all benefit, But in these financial times where it's about a one-year contract, it's about shareholder value, how do you get them to really, kind of explode that box and see things more widely?
Well, baseball bats are useful, but I would say, look, the first thing is to convince them of the cost of doing nothing, the cost of not changing how you're doing business. They're bearing those costs now. Bingo. So yes, it may take a couple years to get payoff for some interventions, but you're bleeding right now by not trying to address them. So that's the first thing. And then the second thing is to help them see how a joint project may end up being more effective than the one-offs, doing it yourself. Now that's actually the hardest leap because they're used to being better than their competitors at everything. But we're talking about a world in which most health plans don't have deep expertise. The deep expertise on how to actually help people with health-related social needs lie in those community workers in the community and lies in those CBOs, those community-based organizations. And the more health plans come to recognize that, then you can build a really effective partnership where you rely upon the differential and complementary expertise of these organizations. So that's, I mean, obviously then you got to measure it. You got to measure what you care about. And that's where the data infrastructure really matter. And we can probably talk about that until cows come home, but I think I should stop now. You're muted, Vince.
Sorry. Thank you very much, Len. Anybody else want to chime in on this issue of sustainability?
Yeah, I think that getting started is the most important challenge that we have to overcome and create an incentive for it. And I fully believe that that's where a government can play a role to create that incentive, create that measurement infrastructure. I remember conversations with my governor, Governor Carney, where he would say, Kara, that's great, but I can't afford to save money, because the ask is always about this upfront investment and barrier. I just think of COVID and the opportunity that we are in the midst of, and the case to invest in social determinants to keep everyone healthy is no more valid than today and now. And so can we use what may not have been spent in other areas because of the pandemic to invest in this change? It just seems that we could make that case. And it is a societal direction that we need to choose. We do need leadership to say it's important. We need local leadership to say, I want to do this for my community, for my city, for my county, for my state. And I think that there are ways to do that that are politically feasible. I'm not a politician, but you need to put something in front of them that's on a 2 or 4 year horizon, right? And create that kind of legislative push or some a way to track, measure, assess whether you've had impact. And I think there are opportunities to do that. And there are a myriad of ways. And I think we've actually included some materials about examples of how that's been done successfully in different places in the country.
And I would just echo what Kara said about leadership. I was thinking the same thing. It's so important to have leadership. I mean, ideally at the top, at a governor level or at legislative level, but at the top of organizations to kind of set a vision. Like this is what we're striving toward, and then this is how we're going to get there. And I mean, I mentioned that SHARE initiative that started off as state legislation around spending around social determinants of health. I mean, that is another way to get at sustainability. It's, I guess, more of a stick than a carrot, but it's kind of partnered with and complements the vision and that we have in Oregon for our Medicaid program and promoting health and kind of holistic, health for all Medicaid members.
Any other comments before we open up for the audience questions, which honestly is always my favorite part?
I just have a quick comment on measuring progress that Kara was talking about, and bringing in Chris's comment about technical assistance into that. So in order to measure progress, the community organizations don't necessarily have the capacity to do that or the skills to do that. And so I think that's where, there is a role for, many agencies or organizations to provide technical assistance. And CDC and NATO and ASO recently did this by providing, and we at Mathematica actually supported this and provided the technical assistance in order to help a national set of community collaborations to build the skills to measure their progress towards their goals. So just want to highlight that. Thanks.
Thank you so much. So I think at this point we're ready for audience questions. And so this means that I need to bring out my glasses so that I can actually read what I'm being told to ask. So do we have any audience questions to tee up? I see. So I apologize. I'm having problems finding the messages. Found it. Okay, thank you so much. There is still... So social determinants of health would seem to be a starting point. How do you recommend that payers and stakeholders collect and share social determinants of health data and track progress, including data on race, ethnicity, and language? How can payers and their partners avoid creating or perpetuating fragmented data collection systems? Excellent question. Who wants to answer? We've touched on this, and I think this is diving a little bit more deeply on the issue of kind of how do we make sure that this data is interoperable, comparable, and that we're not further fragmenting what already, very fragmented data systems.
Well, I'll go first since nobody else seems to be jumping in. I'll just observe. I was part of a conversation not too long ago, I won't tell you where health plans and hospitals were debating which social determinant was the most important. And the hospital said, well, food is a much bigger problem than homelessness. Almost everybody we treat has a home. And the health plans ask them, where do you live? So what was going on was when a person goes to an ED, they ask where you live, and a homeless person will give them an exact address because that's where they get their mail, which they expect to get from the hospital after they're home. But they don't have a home. And so the hospital was writing down, everybody's got a home, and the health plans are over here trying to find the homeless. So it's really true that what you measure matters and how you measure it. And the only way to solve that problem in that community was for the systems people to get together and try to deconstruct what you think is true about Lynn as opposed to what somebody else knows about Lynn. And that's, so first of all, you got to agree on how to measure stuff. Second, you got to have an infrastructure that people agree to use. And that's where these closed loop referral systems like Unite Us or the community-based versions out of San Diego, those things can be phenomenally valuable, but they need to be governed at the community level and they need to be accessed by all, including the patients, so they can get their own data right.
Anyone else have thoughts on that?
I'll just add, I'm not a data expert at all, but in Oregon, we are trying to kind of patch together a series of community information exchange systems, which is what I think Len was referencing. And being able to share data between the healthcare and social service system is really key here. And in an ideal world, so I'll put it out to other states that haven't gone down this road yet, creating a centralized kind of coordinated community information exchange would probably be ideal. In Oregon, there was already activity happening in a number of regions, and so we're looking at ways to connect all of those. But it's an effort that will be, if we can be successful and get that those systems up and running and kind of all talking to each other, really important for this work.
Yeah, I would just add that doing this work is really challenging, and who collects the information is important. But I know, from our providers who are trying to learn about social determinants of health screeners and how to collect this information and do this universally, it is a tension and time challenge that they're trying to figure out. And we're also a health system that's large and diverse, and some of our practices want to customize even our locally customized tool to be more appropriate for their geography and their smaller unit. So I think that's really something we have to figure out. Although we want better data and higher standards of quality, I think back to your point earlier that we may have unique needs that fall off of a standard screener that's validated and appropriate for larger populations. We also need to be flexible as we're thinking about things and then provide that as a feedback loop. I think it's just our ongoing learning around data and Z codes and who collects the data and at what level the accountability should remain.
Yeah, thank you so much. One of the things that, Len, really struck me from your answer was just the initial premise of, entities arguing about what was a more important social need. And I think that belies the challenge of the most important social need for different communities may be different. And we need to figure out how to deal with that. And even when you're looking at larger conceptions of communities, like let's say you're looking at the Latinx population, there are very different, there can be very different social needs depending on, what subgroup, right? Puerto Ricans are born citizens, like I am, and don't have to worry about issues of immigration status. But other communities who don't have that benefit have a whole other layer of potential social needs connected to their immigration status or the immigration status of people in their family, et cetera. So thank you for kind of raising that issue. There needs to be a way that we can allow for the flexibility to tailor screeners and tailor the categories and data collection so that they're relevant to the community that the provider is in, and at the same time figure out then how can they be, folded up into larger categories, or how can we make sure that we don't end up fragmenting the data so much that it's not as useful as it could be. Any other comments on this question? Great, so let's go to our next question. How can, here we go. Can you speak more, this is very related to what we were just talking about. Can you speak more to the health equity measures to focus on?
Yeah, I think I raised that in my comments, and just to our point about social determinants, I think the health equity measures also have to be locally relevant and will differ and vary. Even the racial and ethnic categories that you collect and aggregate might need to differ based on where you are. So it's a hard question because it depends on where you are. We at Demars have two different hospitals, one in Delaware Valley and one in Florida. And I will say that the equity measures of importance are going to be very different because of those two contexts. It also presents a different challenge when you're trying to create the intervention. What I think is important, and a general statement that I can make, is that creating that visibility and creating the opportunity for engaging the community is critically important. And then figuring out how you add that into maybe your Medicaid managed care contract to create an incentive so that the providers and the practices can actually close those inequities. That's where I feel compelled that we have a chance to actually close some of our gaps that we know have been longstanding in healthcare. So trying to add an incentive, also adding that data and technical assistance. And there are many amazing firms out there trying to help both payers and health systems and local providers, smaller practices, figure out how to look at equity in very different ways. I think there are examples from Pennsylvania adding it in as a quality bump for some of the providers into the MCO contract. There are definitely opportunities in the commercial segment for those that are larger to do the same. So it will vary. We're looking at examples out of Minnesota where they've really focused in on some refugee populations there, where there are very specific language and perception biases around certain vaccinations. So it can vary, it should vary. And I hope that answers the person's question that came in. I think it's a challenging one. There probably are others on the panel who have examples that I think are very relevant to this need.
And just as a reminder, there's a nuanced issue here of there are people, at the federal level, and across the country working on health equity measures kind of as a global thing, like what kind of index and how do we come up with, if we measure this and multiply it by X, Y, I'm not a math person, Len, you can help me out, country economist here, to come up with these are wanting to do kind of almost like if they were, Medicare star, kind of ratings or other kinds of ratings or indexes. And that's not what we really are talking about here. That's not what Kara's talking about. And it's really about the very, very basic fundamentals of collecting race and ethnicity and language and other relevant demographic information, and not just being able to say, I have X number of Latinx people and X number of Black people in my pool or in my organization, but actually then tracking outcomes, tracking interventions by those categories as well. That is the way to really make progress, and anything built that we want to do beyond that without having that fundamental infrastructure that I would say should be built by those that have the resources and then made available to the CBOs and so forth. We need to get that right first. And let me tell you, some of us have been trying for more than 20 years to get that right, and we still haven't succeeded. So that is, I think, the biggest takeaway, to make sure that you are starting off with just collecting this data by race and ethnicity and what other relevant groups, as well as then stratifying, disaggregating results and other data by those categories. Does anybody else want to add something to that, or should we go to the next question? Okay, so next question. How can payers go beyond traditional approaches of measuring return on investment to measuring return on value and using data to build the business case for change? How can payers secure buy-in from senior leadership when the value of SCOH policies will take longer to realize than other investments, and for some benefits that are not monetary in nature? Len, I think I'm going to start with you, because you think about this a lot.
I'm happy to start, but I'm sure others have points to make. But I think one way to approach that question is to have an organization assess what are its objectives. Every health organization, be it an insurer, hospital, has multiple objectives typically. Now, if you want to get a CFO to agree on a new investment for which they're bearing full risk, you better have a pretty good promise of financial return. But if policy's smart, and I'm not saying we're there yet, but we are moving in that direction. If policy's smart, then we can reward them for doing what they also care about, which is making their people healthier. So I think the first thing is to get the policy matrix right, so they're, in a sense, free to do what would benefit the patient or enrollee or whatever. And that turns out to include health-related social needs. And once you get to that place where they are not going to be penalized for trying to help them outside the hospital or the healthcare system, they're going to do it. These people are not averse to improving people's health. It's not that big a stretch, but it is a stretch when you put all the risk on them of achieving a 100% financial offset by excluding it from the MLR or preventing Medicare fee-for-service from doing it. So it really has to do with the policy environment and then the awareness of the C-suite with that environment. Now, the long-term payoff problem is endemic to capitalism. It's probably worse now than it was 10 years ago, because we have all these corporate raids and management get fired more often. But I would say the way to solve that problem is, again, think about the metrics by which the public programs reward the actors. If you say you're going to get a quality bonus for having children, let's just say something simple, not having asthma or not having asthma exacerbations and having to go into the ED, then by God, they'll invest in that, even though the payoff may be a couple years down the road. So it all has to do with linking the values of the society as reflected in policy with the objective of the organizations who are trying to serve. I firmly believe, Cincy, in almost every case, it is possible to tie the self-interest of an organization to the social interest in what we're all talking about, but it requires constant interactive policy development and communication with C-suites.
Yeah, I think that the other cross-sector lever that's out there is trying to figure out how to engage leaders, and whether that's through children's cabinets or family. We had a family services children's cabinet that would come together around these cross-sector social needs. And we had regular conversations about how to invest and how to collaborate. I think that there is some interest in doing that. We don't have that same structure federally. I know Demars has been pushing that we create kind of a structure to do some cross-agency work and create some leadership, because I think this challenge around siloing funding is very difficult, and it trickles down to the state level. So, pulling together both the measurement and the leadership and the opportunity could happen, but it does take a bit of a push and a bit of a willingness of both government and political leaders.
And going, kind of echoing Len's comments and taking it to a kind of a specific example, the health-related services program that I mentioned in my earlier remarks, with regard to return on investment, what we ask the CCOs to report is what they anticipate the outcome of the longer-term outcome of their health-related service kind of being, and to share with us some sort of evidence that the program or service that they're supporting, has. And the literature, government entity kind of shows some sort of evidence there. So we don't require there be a demonstrated longer-term impact, obviously, because these decisions are made on a year-by-year basis, but kind of trusting that the combination of the evidence and the demonstration that the CCO has given thought about what the longer-term impact would be is sufficient for the state to incorporate consider those the spending on those services in that performance-based reward program that I mentioned.
Yeah, and picking up on that, there are often intermediate time level horizon milestones that are between the long run impact and today's activity that you can decide to reward as well.
Yeah, I've also seen modeling. I think I saw this specifically in Connecticut when they were trying to figure out how community health workers would make a difference. And it included financial return on investment and then also social return on investment. And they measured things like how many days of school were not missed or how many work days a parent didn't miss and things like that, which may not convince the CFO of an organization. But nevertheless, I think are important to also talk about to start doing that job of broadening the aperture of how people are looking at healthcare investments. Okay, so I think we have time for one last question. And this one was specifically, Kara, you were specifically requested. You mentioned learning from what Medicaid has learned works for screening and referral. Can you please share some of those specific lessons?
So I think they're talking about our social determinants of health screening comments in Medicaid. Is that okay? And I do think that we are learning. So for my day job at Demars, we are implementing a universal social determinants of health screening tool. But I think we're also hoping that in the future we're held accountable for that. And we're aspirationally thinking about these other measures to our prior conversation about things that we know matter for kids like kindergarten readiness and literacy outcomes. And can we measure whether our students are able to attend school, and is there a way to connect the dots around absenteeism or high school graduation rates, things that we know matter. But we're not there yet. Right now, we are understanding, just like many systems, what it means to just ask the question and then create these linkages. Right now, we are referring, we are partnering with community-based organizations. We have a medical legal partnership that's helping with some of the housing challenges right now. These are all lessons. They are not perfect. We are focused on the Medicaid population. I think the other part of my remarks earlier were specific to my thinking as secretary when I ran a big agency that had Medicaid and all of the social service programs the state could offer, is that it would be easy to combine them. And the reality is it's very difficult to do that. You almost have to do it pen and paper because of how challenging it is to get the data to talk to one another, or you have to throw tens of millions of dollars into very fancy ways that connect very protected data. And so I think that is where we see this opportunity to leverage community health workers who, honestly, if you just ask them, they know who the most vulnerable people are in their community. They know who really needs additional resources around food insecurity and transportation. And so in some ways, we're building out very fancy things, and the researcher in me wants to see the data and wants to look at the high impact opportunities, but we can just do this based on, paper, pencil, walking the streets, getting to know people, and trying to figure out how to make programs work better and more effectively and create a way that is much more friendly. It's not a phone app and it's not a click away. It really is just talking to people and trying to see if there are other ways that we can help and connect the dots.
I just want to build on that a little bit and just bring it down to the provider level and the individual practice level. In that, one thing that we've learned through the AHC model is that it really takes a lot of buy-in at all levels to make screening happen and make it work and make that referral process smooth. So, it could be that the people, running the office are totally buy into that and really think it's important and understand it, whereas the leaders of the organization or the practice don't see it. Or the opposite. It could be that it's, a message from leadership, but, the front desk people who might be responsible for screening don't have time and see it as an additional burden. So I think it's really about having that buy-in at all levels and finding ways to cultivate that. And that's kind of one of the biggest lessons that we've learned. So.
Yeah. And I think also part of it is thinking, often we hear like, well, doctors don't have time for that. And it's like, no one's actually saying it has to be a doctor to do it, right? And probably might be even better if it's not the doctor. You might get more honest answers if it's not the doctor who's doing it. And so it really is about how do you invest in support kind of these diverse teams. And I don't mean diverse just by demographics. I mean like, diverse teams, team-based care that might include the community health worker, also talking to, the nurse, also talking to maybe a physician's assistant, also talking to the front desk. And we need to figure out how we support that kind of collaboration. Great. So before we close off, I wanted to give really quickly, we're going to have a lightning round to give our incredibly insightful, smart, intelligent speakers a chance with just in a minute or less to tell us what is one key next step payers interested in working on social determinants of health for advancing health equity should take. So this is like a popcorn. This is lightning round. Who wants to start?
I can go. So lightning round, I would say just identify one strategy and just start working on it. Recognize, I think I mentioned this before, you can change the approach over time. It can evolve. You can add to it, but just start doing something and allow for flexibility and implementation. Kind of set that goal and allow your partners to be creative in how they achieve the goal, and provide a little technical assistance and capacity building too. Okay, I'm done. Thank you.
I would say pool their funding together with others in the community to invest upstream, especially in kids, because we know the healthcare dollar doesn't focus early in life, but it has the greatest potential return for society.
I would say to build on that, to also think about creating flexible funding pools that community organizations can apply for in order to support their clients and patients. Like, for example, domestic violence housing first pilots implemented in Washington State and California. Many of those participants receive flexible funds for rental assistance or moving costs or transportation. And, the evaluation showed that most of the participants use those flexible funds to prevent homelessness. And so just another plug for flexibility and the ability to meet individuals' needs.
So on the theme of flexibility, I'll close out by saying, be flexible, get on a plane, fly to DC, surround HHS, and don't leave until CMS has agreed to let you pay for stuff in the MLR. I mean, that's really what it comes down to. You've got to get that conversation between what a lot of folks could tell you what will work, and if you get the right CBO partners and infrastructure, you can make it work, but you can't be bearing 100% risk, and it's not going to happen at scale unless you do that. So go to Washington and don't bring guns, just go to Washington and talk about MLR. There you go.
Leave it to Len to provide a very, very concrete call to action. I first want to thank you all so much for this conversation. I'm consistently impressed with all of you. We hope for the audience that this has been a helpful conversation, that it's been motivating, maybe even a little bit inspiring. If you want to share these powerful insights with others or just review them again yourself as, just to remind yourself of all the potential that we have, a recording of this event and all the materials with it will be shared with you in the next few days. Also, we really, really, really would appreciate you sharing your thoughts about promising payment policies that can advance health equity by working with social determinants of health by completing the survey that I'm told you can find by clicking the teal clipboard at the bottom of your screen. And also, I think it'll just automatically open when the event concludes. So just to finish off, I just wanted to kind of summarize in the following way. This last year and a half has painfully demonstrated